Hello, this is your brain on drugs, and this is the punk rock psychiatrist. And that was Weight of the World by Good Riddance, another Fat Records band, kind of play on words with what we're doing now with the Fat Records and also Weight of the World. So thought I'd use that one today. I don't think I've used them before. And so today we are going to talk about the individual GLP-1 medications. So you've learned all about them, how they work, what's good about them, what's bad about them, how to mediate that. And now you're probably wondering, which one do I pick? Which one's better? Which one might be better for one patient versus another? How do I dose it? What if I run into issues with individual meds? Well, that's what we're going to talk about today. And we are going to start at the beginning. As you remember, when I first started talking about GLP-1s, I said that this research started back in like the 1980s when they looked at the Gila monster. It's a big desert lizard in the southwestern part of North America, kind of United States, I believe Mexico as well. And this lizard only eats a few times a year um, because it lives in the desert. And having this GLP-1, this strong GLP-1 in its system, is part of the mechanism by which it does that. And so by 2005, the first GLP-1 was discovered. However, as you'll note before, we talked about this was not for weight loss in the beginning. These were diabetes medications. And I believe this was exenatide was the only GLP-1 that was out at the time I was going to medical school. So it was the only one I really learned about. And I don't even remember learning about it. I'm not, it was a new medication. It was expensive. Is this something that was all that much better than other diabetes medications? It wasn't necessarily clear at the time. So, as a medical student, I didn't really see it, and it's not really used anymore. But, let's go back in time and talk about these earlier GLP-1s so we can kind of bring our way up and see how they progressed. So first was exenatide, and I think the other point, 2005 Byetta, that's the brand name. The other point about this is, a lot of people say, "Oh, these are a new thing. I don't, we need to see what happens first." I mean, this was discovered in the 80s. It was researched all the way up until 2005. It was approved by the FDA, and it's been in existence for 21 years. So these medications have been around longer than a lot of other medications that we use. A lot of psychiatric medications have not been around since 2005. And so I think, I mean, look at some of our newest antipsychotics. They have completely different mechanisms by which they work. And those mechanisms have only existed for the last few years. And I think no one says, let's see what happens with this antipsychotic. But for some reason, they want to see what's going to happen with these. They're, more scared, I guess, that something bad's going to happen. But I don't know that there's a signal that there's any more risk with a GLP-1 than anything else. And then the fact that these have really, like, this mechanism of action has been understood for like 40 years, and we've had medications for over 20 years. So, you know, the newer medications, of course, they're different. Um, the fact that they're being used en masse, I think like marijuana, like we didn't realize quite how bad it was until everyone started using it. So there is a point there, but at the same time, like, at some point you have to just be like, hey, this is just as good as anything else, and we have to see what happens. And there's risk with anything. So, exenatide, Byetta, 2005, first GLP-1 receptor agonist. Average weight loss was pretty meager, 2.5 kilograms. Only approved for diabetes type 2, not for weight loss. And then another version of exenatide, Bidurian, came out in 2012. This was actually the third GLP-1, but I'm talking about it now because it's also exenatide. And the reason was Byetta is subcutaneous, so this is a shot in typically the fat around your midsection, right? You pinch and then you put the shot in, and it was dosed twice a day for those 18 and older. So I mean, this is our first shot at no pun intended there, of using a GLP-1, and it's like can only be used in adults. You had to take a shot twice a day, but at the same time, like insulin was dosed sometimes 3 or 4 times a day, especially back in this time. Insulin is not used as much as it used to be, and one reason is because we have newer medications like this out there that are better. So the fact that it was dosed twice a day was not necessarily something that was like a lot different, but a lot of people don't want to take a shot twice a day, right? um Byetta, and then Bydureon came out in 2012, and it was a weekly shot, and it was for those 10 and older, so this was a pretty substantial step up. Byetta was a little bit better. Sorry, Byetta was a little bit better for weight loss than Bydureon, and at only 2.5 kilograms, not great, right? So let's go forward in time to um, our next medication, and I think there's one that yeah, Victoza, liraglutide. That was actually our next one, but I'm gonna save that for when we talk about when Saxenda came out. Let's cover these diabetes ones first. So the Victoza did come out in 2010, and I'm going to talk about that in a second. But the next one I want to talk about is dulaglutide, or some call it dulaglutide. Um, these medications are all produced by either Eli Lilly or Novo Nordisk, and it seems like one of the companies prefers the dulaglutide type of pronunciation, and the other one the dulaglutide type of pronunciation, or one of the two, and one's like it doesn't matter. I can't remember which one of them made dulaglutide. I just pronounce them all like that. I do them all, exenatide, dulaglutide, liraglutide, semaglutide, tirzepatide. I try to keep that pronunciation going, but you will hear the other pronunciation as well. So then dulaglutide, otherwise, which is how I pronounce it, right? So otherwise known as Trulicity, came out in 2014, GLP-1 receptor agonist. Um, the weight loss, not really that much different. I mean, this one's reported in pounds, 6 to 10 pounds. 2.5 kilograms is around 6 pounds. So maybe a little bit more weight loss with dulaglutide than with exenatide. This one's also only approved for diabetes type 2, not for weight loss. This is also 10 and up, like Bydureon was. And it's dose 0.75 to 4.5. This is also a subcutaneous injection weekly. And this was actually the first GLP-1 that I ever remember encountering. And it was through Trulicity that I realized that these things were out there, and that the weight loss versions were out there. And I started digging into these. So I had a patient with type 2 diabetes, and they were on this, and I was like, I'm not familiar with this medication, and that's where all this started. So the next medication is a combo pill. This one's less important, but this is for completion's sake. There was a GLP-1 called lixisenatide. That's a hard one. Lixisenatide, Lixis. So I think it should be called lixisenatide. Why is it lixisenatide? It's kind of hard to pronounce. That one was taken off the market. Its brand name was Adlixin, so it's no longer available in the U.S. It may be available in other countries. But in the US, there is a version of it that is combined with glargine, which is a type of insulin. And this branded product is called Soliqua, came out in 2016. It's only for diabetes type 2. I don't know how much weight loss is on this. I don't know. I've never seen it used. So I found out, I was like, oh, lixisenatide. There was some studies on this medication, and then I saw, oh wait, there's actually a form that's still out there, and that's what it is. So let's move to the next one. This is liraglutide plus insulin. We'll talk about liraglutide next, but liraglutide Victoza came out in 2010. This is liraglutide plus insulin. I'm not even sure how to pronounce this brand name. It's Xultophy. So I'm thinking Zoltofi, maybe. Came out in 2016. GLP-1 receptor agonist with insulin, only approved for diabetes. All right, let's get into the good stuff. So let's talk about liraglutide. Um, and then this is Victoza for diabetes, came out in 2010, and it's Saxenda for weight loss that came out in 2020. So this was really the first. I'm not really. This was the first GLP-1 that was used that got an approval for weight loss. All right, so I think what we had was you had patients on Victoza, like, so these medications have been out for a while, right? I mean, 2020. I mean, we've had 15 years of GLP-1s. The exenatide, not a lot of weight loss with that one, but then Victoza, they were like, hey, there's like some pretty significant weight loss here. Maybe we could get a weight loss approval from the FDA after they kind of saw that that was happening. And if you remember, like a lot of diabetes medications actually cause weight gain, particularly insulin. It's kind of mixed. Some of them cause weight gain. The older ones cause weight gain. The newer ones are either neutral or cause a little bit of weight loss. But these GLP-1s were causing, some pretty good weight loss, right? So that was noticed with Victoza. And this one is approved. So Saxenda is approved for 12 and up. All of our weight loss drugs, GLP-1s, are 12 and up. There's some that are lower. I'm going to have a little pediatrics slide probably next episode where I'll go over all the ones and all the ages so we can kind of get that out there. So Saxenda is 12 and up and Victoza is 10 and up, but that one's only for diabetes. The average weight loss on this one, 8.4 kilograms, plus or minus 7.3. So, like, that's pretty significant. I mean, if you remember, the ones up to this point are like 2.5 kilograms. And so 8.5, I mean, that's pretty substantial. That's about 15. I mean, that's like 17, 18 pounds. But really what we want to know about is percentage weight loss. That's a little bit more useful. And if you remember Qsymia, our best medication up to this point is about 10% weight loss. Liraglutide is probably in this kind of 12 to 14%. So we're a step up from that. Because, I mean, the average weight, I mean, unfortunately, they just report this in average weight loss and not in percents. But I think if I go back pretty far here, I think I had the percents and they were like 12 to 14%. So yeah, I looked back and I don't see a percent reported for this. So they just kind of reported this in weight loss, which honestly is not that useful because if depending on I mean, people could be a lot different weights. And so just strict kilograms lost, how big were these people, right? Were these 200-pound people or 300-pound people? So that's going to make a difference there. And it was so 8.4 plus or minus 7.3 kilograms and 5.6 kilograms more than placebo. So, I mean, that's about what, 14 pounds more than placebo. So that's pretty substantial, especially when we're trying to hit that 10% weight loss mark. And of course, we also have the placebo effect with it. So it is more like the 8.4. So that's, close to 18 pounds or so. And that's about 10% of a lot of people's body weight. Probably in around 200 to 250 pounds, a lot of the folks that are obese. So we've also had some studies on antipsychotic induced weight gain. And with this medication so far only benefit for prevention. So kind of like metformin and topiramate, it's just benefit for prevention, but not weight loss, but probably more studies to come. But like, this is probably not the medication we're going to be looking at because you'll find out in a second. How is it dosed? 0.6 milligrams to 3 milligrams. This is another subcutaneous injection. On this one, we have to do it every day. And that dosing range is actually higher. The highest dose is higher than Victoza. So it's not the same as Victoza. This is where I think people get confused with like Victoza versus Saxenda or Wegovy versus Ozempic. The dose, even though it's the exact same drug, the dosing range and what it's supposed to be prescribed for are different. So this is a daily injection, which is one of the things that makes it not as great of an option as a weekly injection. I mean, people don't want to stick themselves with a needle every single day if they don't have to, right? The pen injector has got some positives and negatives. So You actually, like, the pen is multi-use, but the needle, of course, you need to change after each use for sanitary reasons. But when you look at semaglutide and tirzepatide, it's a single-use pen. So this is a 1 milligram or whatever pen, right? And you jab yourself, stick it, it injects everything. You throw the whole thing away, and then next week you use a completely different pen. With this one, probably just kind of save on waste. It's multi-use, so you kind of dial in the dose you want, and then you stick yourself and inject it, and it'll inject up to that point, and then there's still medication left in the pen. You replace the needle, and the next day you use a new needle. And so you use the zero point 0.6 milligrams every day for a week. Then you move up to 1.2 milligrams every day for a week, 1.8 every day for a week, 2.4 every day for a week, and then 3 milligrams. And of course, you can stop at any point depending on, if side effects, you can slow down, whatever. But one cool thing about that is we're actually getting to the max dose within about a month. Okay. So you can actually get all the way to the max dose in uh, about 4 weeks. Okay. So potentially, if they're able to tolerate the titration, but that's how it's recommended by the manufacturer. And having that pin dial in, it also gives us more ability to like not have to deal with shortages, because with the later products it's like, oh, I need a pin at this dose, and now I need a pin at this dose, and when you're prescribing it, you have to prescribe a box of these, a box of these, as we're titrating up. Oh, you need this dose, you need this dose, I've got to give you 4 of these pins for the 4 weeks of this one, and 4 of these pins for this one. With this one, with the Saxenda, you're using the same pen for everything, and you just dial in the amount that you need and then inject it and then use it until it's out. So that it's less convenient, it's less simple for the patient, but it also is going to make it more flexible with how you dose it. You could even dose intermediate doses, or you have more flexibility with it. So the advantages that I would say over Wegovy is, so Wegovy is our next product, so we're going to compare it to Wegovy, because Wegovy came out next. We don't have Zepbound yet, so we're going to compare Saxenda to Wegovy. So it's when Wegovy had shortages and it was difficult to find it, and we talked about shortages before, this one would then be more available, and you could kind of use it to bridge. And you could say the lower doses of Wegovy weren't available, but the higher doses were. Well, you could titrate up on this one and then switch them over from the 3 milligram of Saxenda to the 2.4 of Wegovy. And you could actually get them up quicker too, 5 weeks versus 17 weeks. So the dose titration potentially faster. And then also, this is generic now, so it may go down in price. I don't believe it has. I'm not aware that it has at this point. But that's also another potential advantage, is it could end up being cheaper sooner, so that those that couldn't afford anything could at least take something. And then maybe Saxenda becomes, even though the weight loss is not as good and you have to have to give yourself an injection every day, it may be better than nothing. All right. So that's Saxenda. I would say, if just overall, when would I use it? Pretty much never. I have used it, but that was when we had shortages of Wegovy. So I'd say, if you've got shortages, if you've got like insurance issues that are hard to get around, perhaps that this might be another option that you have. If you're out of Wegovy and you need to skip over some doses, you can bridge with this one. The generic thing may come in handy. But let's go ahead and talk about semaglutide, or as some people say, semaglutide, brand name Wegovy. I mean, this one came out literally the next year, 2021. So like, Saxenda was out for a year before a much better product came out. And we'll talk about why it's better, but let's cover, like, what is it, right? It's another GLP-1 receptor agonist. And this is going to be the last one, or the next one we're going to talk about has different functionality. So this is a strict GLP-1 receptor agonist. And there are 3 branded products. There is Ozempic, which is a weekly subcutaneous formulation approved for diabetes type 2 in 2017 for those 18 and up. Ribelsis, which came out in 2019, which is a daily oral formulation approved for diabetes type 2 in 2019 for those 18 and up. And then Wegovy, weekly subcutaneous for those 12 and up. And now we have a daily oral pill, which I'm going to talk about separately, for those 18 and up, that's approved for weight loss, as well as metabolic associated steatohepatitis, so otherwise known as fatty liver disease. So, but not just fatty liver disease, fatty liver hepatitis. So a severe case. I don't know how many folks are using it for that, but it's the only medication I'm aware of that is approved for that, and it's certainly the only weight loss medication that is. So this one's got the two approvals, weight loss and MASH, and people had like it was the Wegovy version was approved right after Saxenda, so like Saxenda really didn't have much time to like be something that people would want to take. Other than when this first came out, of course, the first year or so it can be hard to get. But people were taking Ozempic earlier. Like Ozempic had been out for 4 years prior to this, and there was already, people already knew about the weight loss that was happening. They knew that they were trying to get this approval for weight loss. And so a lot of people were taking Ozempic kind of off label for weight loss, but they'd have to pay out of pocket. And I think that's why basically all of these medications got labeled Ozempic. This is the Kleenex of GLP-1 receptor agonists. Kleenex being a brand name product for tissue paper. And Ozempic, everyone freaking calls this stuff Ozempic, all these medications Ozempic. It irritates me because pretty much none of it's Ozempic, but they've just decided we're going to call everything Ozempic because we're simple. Anyway, that's a pet peeve of mine. Don't call it Ozempic unless you're actually using Ozempic. And then also don't give people Ozempic for weight loss. Like that was another issue we talked about last time with the shortages. Like you have people with diabetes that can't get the medication because you've got people paying out of pocket because doctors are prescribing Ozempic to people that just feel like taking it. And then there's not enough for the diabetes folks out there. That Ozempic is supposed to be for people with diabetes. It also is dosed lower, like the max dose is lower, so you can't take the highest dose that Wegovy is with Ozempic anyway. So let's talk about how much weight loss we're getting from this one and how it's better than Saxenda. So the average weight loss in the step 1 trial, which was one of the earlier trials that they used to test this, showed a 15% weight loss or 12% above placebo. So that's pretty substantially above what the Saxenda was. And the step 4 trial, which was a later trial, they did a switch to placebo at 20 weeks versus a continuation of medication to 68 weeks. And there was a 17.7% weight loss. So like even better, right? And if you look at the graph, I've got it in my slides, you can see that there's a substantial amount of weight loss up to week 20. And then some of the patients switch over to placebo, and they actually, so not only do the folks that have lost weight, everyone that's been on the semaglutide at this week 20 has basically lost 10.6% of their body weight. The ones that stay on it out to week 68 will continue to lose every period they measured up to 17.7%. It starts to flatten out around week 52, but even after week 60, there's still I don't know. It looks like from week 60 to 68, it's pretty much the same. So by week 60, they've kind of got that max weight loss in this trial. But then the placebo folks, they gain the weight back, right? And the placebo folks, they don't know that they've been switched off of semaglutide and onto placebo, right? They're still taking an injection, but they end up, they had lost 10.6% of their body weight, but by week 68, they were only down 5.4%, right? So they basically went from a 10.6% loss up to a loss of 5.4% from where they started, right? So they gained about half the weight back. And that's something that we do see. is that folks have a tendency to gain the weight back when they come off these medications. And then there was the step up trial. And this is one where they looked at higher doses. So this was a triple dose trial. This was done after Wegovy was already like approved. And they looked at a 7.2 milligram subcutaneous injection weekly. And that's 3 times the 2.4 that we have now. And there was a 20.7% weight loss. So weight loss similar to what we see with tirzepatide. And that's that. So maybe that higher dose will get approved at some point. It isn't right now. At the same time, tirzepatide is better tolerated. So even if you took the higher dose of the Wegovy, if that becomes available, you may not be able to tolerate the nausea and so forth from it. But the point is, it seems to be that the difference between what a lot of these GLP-1s and the amount of weight loss that they have is more like the dose that you're getting. So that higher dose, more loss. And that's not always the case. I mean, some folks might be maybe thinking, duh, you take more, you're going to lose more. Not necessarily. You're going to plateau at some point, and you're just going to cause, with any medication, at some point you don't gain any more benefit and you start getting more and more side effects, because whatever receptor is being occupied by that drug, at some point it's just completely occupied, and there's nothing else for it to do at that particular receptor. It starts going to other receptors, causing other problems. All right. So as I talked about, we're kind of comparing Wegovy with Saxenda when there was a head-to-head trial done, and a pretty significant difference. So 16% weight loss with Wegovy versus 6% on the Saxenda. 3% of folks stopped taking Wegovy versus 13% stopped taking Saxenda. So that's pretty substantial as well. So it works better and it has less side effects. And those are really the two most important things that we care about. So it's just a superior medication. That's why you don't see Saxenda out there anymore. It's dosed. As I said, this one goes up weekly. So you start out at the 0.25 milligram subcutaneous dose once a week for 4 weeks. So you take it, say you take it on Monday, next Monday, so 4 more Mondays in a row, and then at the next Monday, you would go up to the next dose of 0.5. You do that for 4 weeks, then you go up to 1 milligram for 4 weeks, 1.7 for 4 weeks, and 2.4 for 4 weeks. Or sorry, no. Once you get to 2.4, that's the max dose, so you stay there. And then you can get either a 28-day supply or an 84-day supply of that one. And then what are the advantages? We've already kind of talked about it. More weight loss, quite a bit more. The weekly injection is more convenient. There's less adverse effects. And then the pen injector, it's easier to use with the single pen for injection. We talked about that too. All right. So all around, this was a better product, and everyone called it Ozempic, even though it is not. Then we had we'll talk about tirzepatide in a second. Let's talk about oral Wegovy, which just got approved like a couple months ago. So this is, and it's also called Wegovy, but it's like PO, per os. PO means by mouth. Per os is the Latin. So it's Wegovy PO. It was approved in 2026. It's the same medication, GLP-1. It's similar to Rybelsus. Remember, there's also the oral Rybelsus that's used for diabetes, but this is dosed higher and it works better for weight loss. All right. We've got a couple of trials here, the Oasis 1 and the Pioneer Plus trials. With this trial, they looked at the 50 milligram dose of PO Wegovy, and it was associated with a 17% weight loss. So that's pretty much the same. We had 17.7 with the injection. And so that's pretty impressive. There were A1Cs went down more than lower doses. The oral is less bioavailable. So that's why the dose is higher. Because 50 milligrams every day versus, 2.4 milligrams once a week, right? So you have to take a higher dose. You also have to take this with 4 ounces of water on an empty stomach 30 minutes before you eat. So that's, that's something that if they don't do that, it's not going to get absorbed appropriately and it's not going to work. It's going to be a waste of money. Right. And then we have the Oasis 4 trial that came out, 16.6% weight loss. That's about the same as the 17%. And that was over 64 weeks, so over a year. And they discovered that the 25 milligram dose, which is half of the 50, had similar efficacy and less side effects compared to the 50. And so it's like, oh, great. We only need to do 25. We don't need to do 50. And then this is what it got approved at. Now, if you look at Rybelsus, which is the same drug, also in oral form, it basically is the same medication, but it's dosed lower. Rybelsus, the max dose is 14. You only get 5% weight loss. So really the trick here was basically taking Rybelsus and like making it a higher dose and then calling it Wegovy PO. And then losing 3 times as much weight on it. Okay, more than 3 actually, 5% versus 16.6%. So there's also a request by the manufacturers. We may see FDA approvals of this oral Wegovy for diabetes type 2, but it was approved in January. It was not a couple months ago. It was like 6 months ago, January 2026. And the way this is dosed is you take it it's kind of similar to the other one. You go up monthly. So days 1 through 30 are on the 1.5 milligram dose, 31 through 60, the 4, 61 through 90, the 9. And after 3 months on day 91, you go to the 25 milligram dose. And if you were going to convert between the subcutaneous and the PO, so say you've got patients on the SQ and they're like, you know what, I don't like it. I don't want to keep giving myself shots. Can I switch over to the PO? The 2.4 is equivalent to the 25. So if they're on the 2.4, you can move them over to the 25. So the max doses are equivalent essentially. If they're not on the 2.4, then you're going to have to play around with it, right? Looks like it's about a 10-fold difference. And so if they're on the 1.7, there really isn't a 17. There's a 9. And so you're like stuck. Like if they're on the 1.7, I'd probably put them on the 9 and then see if I could get them up to the 25 and see how that went. So you kind of think of it, it's about, if 2.4 is equivalent to 25, it's about a 10-fold difference there. Now, if you're switching them, say they're on Zepbound, which is another injection, and they don't want to be on injections, they want to be on PO. How do we do that switch? So the recommended is if you're on anywhere between the 5 and the 15, 15 being the max dose of Zepbound, if you're anywhere in between that 5 and that 15, the recommendation is to go to the 9 and be on that 9 for a month and then go to the 25. So if you're switching between the 2 Wegovy products, you can go from max dose to max dose. But if you're switching from Zepbound to Wegovy, the recommendation is to switch over to the second highest dose before going to the highest dose. The Wegovy is very expensive in the US. It's $1,600 a month. In other countries, it's like $300, which is ridiculous, but that's the reality we live with in the US. All these folks going to the World Cup, it's like they're America's, they can't believe how great it is. Well, why don't you deal with our healthcare prices? That there are issues that you don't see when you visit necessarily, but yeah, 1,600 versus like 300. This product is listed as that it costs about 1,600 a month as well, so an equivalent cost. However, with the coupons, it's like $299 a month. I don't know how long those coupons will continue for, but I think they're trying to promote it. It's like, oh, we're going to give you the reasonable price that every other country in the world gets, and then we're going to raise the price on you probably. So that's oral Wegovy. Now let's move to tirzepatide or Zepbound. This was a pretty big step forward. This came out in 2023. This is the twincretin, right? So GLP-1 is also known as incretin, and we've talked about GLP-1, glucagon-like peptide 1, a receptor agonist, but we also have the glucose-dependent insulin insulinotropic polypeptide, or GIP, also known as gastric inhibitory polypeptide. So GIP has two names for some reason with the same acronym. Um, what is this doing? We're not entirely sure. It is GLP-1 is produced, as we talked about, in the ileum by uh, enteroendocrine cells. This is also produced by enteroendocrine cells. This is K cells in the duodenum and the jejunum versus the ileum, which was, and they weren't K cells. I can't remember off the top of my head. It's a different letter cell. Um, but the GIP receptors are in the pancreas, brain, and adipocytes, which are fat cells. So it's thought to have kind of similar effects on appetite and weight and so forth, and insulin release and whatnot. And so first there was Mounjaro, which was approved just a year earlier. So Zepbound came pretty fast after Mounjaro. Mounjaro came out in 2022. Zepbound came out in 2023. Both, and the Mounjaro is the one that's approved for diabetes type 2. Zepbound is only 18 and up. And so with the Wegovy, so if you've got a kid, you've got the option with Wegovy, not the oral, because that's 18 and up, but the Wegovy injectable is for 12 and up. And then Saxenda is also 12 and up for that matter. But with for some reason Zepbound is only 18 and up. I don't know if that's going to change at some point, but that's how it is right now. And remember how we said that Wegovy was approved for MASH? Well, Zepbound is approved not just for weight loss, but for obstructive sleep apnea. All right. Average weight loss on this one is 20%, 18% above placebo. So that's a few percent better than Wegovy. It has less GI adverse effects like nausea and so forth. And that makes it also more likely to work because people are more likely to take it. If we look at the 88-week Surmount 4 trial, there was actually 25.3% weight loss. So it was an even higher weight loss in this longer trial. And at week 36, those were placed on placebo. So they did the same thing as they did with that Wegovy trial, with that step 4 trial where they switched them to placebo. That one was week 20. This one, it was at week 36 they did it. And once again, they gained half the weight back. And interestingly, though, even though half of them gained the weight back, 17% of those that were switched to placebo maintained all the weight loss that they had gained. Now, if you stayed on it longer than week 36, you were going to lose more weight. So kind of same thing as with the Wegovy trial in this tirzepatide Surmount 4 trial. What the patients that were not switched to placebo at week 36 continued to lose more weight. All right. So I'm looking at the chart here. It looks like the average, they started about 107 kilograms. And then by week 36, they're down to about 85 kilograms. And then the placebo group goes up to 97 kilograms by week 88. And the continuing on tirzepatide group goes down to 79 kilograms. So they lost about another 6 kilograms beyond. So even though 17% of those patients that were put on placebo maintained, if they had stayed on, they probably would have lost a little bit more weight. So you probably want, if you're going to switch somebody off, you probably want to have them on a little bit longer, all right, so that they can lose the max amount of weight. And then we have the 72-week Surmount 5 trial. Real creative here. Just we'll keep it nice and simple. They're all the Surmount, and then we have them numbered. And this would be the Surmount 5 trial. This was a trial where they compared Zepbound or tirzepatide to semaglutide, and it showed that it had a 20.2% weight loss versus a 13.7% weight loss. So it outperformed it. All right, which we already knew from previous trials. But this is actually good because it's a head-to-head trial, rather than just, hey, this medication, use this trial showed that you lose this much weight on this one, and this trial showed you lose this much. But here we actually have a head-to-head, which is like, you really can't say that one medication is better than another one unless you would do them head-to-head, because like those other trials, the separate ones, could have been done differently. And it's like, well, maybe if we do them head-to-head, they'll actually look the same. Well, they don't. 20.2 versus 13.7. So tirzepatide, you lose more weight, you have less side effects. It's just better all around. And then this one, though it's dosed, it's about the same time schedule as with Wegovy. So you start with 2.5 in this case, and you go up by 2.5 a week every month, and it's a weekly injection. So 2.5, then 5, then 7.5, then 10, then 12.5, and then you can end with 15. All right. And this one actually has a warning on it that hormonal contraceptives may be less effective, and to use non-hormonal contraceptives for 4 weeks after an initiation or change in dose. And so I've looked into this. It's kind of how I suspected. Like, it's probably the gastric emptying. So you're just not getting the contraceptive into your system as quickly. And so their thoughts are, after 4 weeks, this steady state is caught up with it, and it should be good to go. But when you're starting this medication, it's going to slow down your contraceptive absorption effect, and then it will take a month for that to catch up. And so you don't want to get pregnant during that time period, of course. If you're using your hormonal contraceptive, which is used for all sorts of conditions, if you're using it for pregnancy to not get pregnant, then you want to use a non-hormonal contraceptive. Now that could the thing is, it says use a non-hormonal contraceptive, but it's really the fact that you're swallowing it. It's not the drug itself that interacts with the pill. So if you were to get like a shot or an implant or an IUD or something like that, I would not suspect there would be this interaction. But if you're going to be taking the pill and you're using it for contraception, then you should use a condom or something in the meantime, right? And this warning is only on Zepbound, but it's also on the next med I'm going to talk about. And so I am suspicious that it's actually we should be taking this seriously with all of them, even though Wegovy still doesn't have this warning. Saxenda doesn't have this warning. And I mean, for that matter, Victoza or Ozempic don't have that warning. I would just think with any of these GLP-1s, you should be really careful with this, because you don't want to accidentally get pregnant. That's the whole reason you were taking the pill in the first place. So that's kind of the explanation for that. All right. And then let's round it off today with our newest approved medication. You thought it was Wegovy oral, but orforglipron, otherwise known as Foundayo. I like Foundayo. I don't know how they pronounce it. I'm not sure if they've even told us how to pronounce it. This was just approved like a month ago, I think. So this is a different GLP-1 medication. It's a GLP-1 receptor agonist. It's approved for weight loss. It's an oral medication, kind of like Wegovy PO, but it's not like semaglutide or tirzepatide. It's not one of the meds we already had. It's orforglipron. It's a new medication. All right. One advantage that it has is it does not have the requirements to be taken with water or on an empty stomach like oral Wegovy did. So that makes it a little bit better. You don't have to worry about that. We're looking at its effectiveness, the ATTAIN-1 trial, the phase 3 results, which are typically the ones that we use to get final approval. They were published last year in August of 2025, and they showed 12.4% weight loss versus 0.9% for placebo over 72 weeks. So I don't know, that just doesn't, when we looked at oral Wegovy, we had 16.6%. So we don't have a head-to-head trial, but like as far as I can tell, it looks like Wegovy is better. Of course, this doesn't have that. It doesn't have the empty stomach water requirements. But I mean, is that really that challenging to deal with if we're going to lose an extra 4%, perhaps? It's cheaper than oral Wegovy at $800 a month, kind of list price, but Wegovy's got that 299 coupon, so it may or may not be cheaper. And so it kind of depends what what the insurance companies do and whether you have this coupon or not. And so it's not clear whether it's even going to be cheaper. Um, and it takes a really long time to titrate this medication, like a really long time, like 151 days. So it takes like almost half a year. uh, you're on zero point 0.8 milligrams for a month, then 2.5 for a month, then 5.5 for a month, then 9 for a month, then 15.5 per month, then 17.2. And another issue with this one that I haven't heard anyone mention, but it's listed in the package insert. It's metabolized by CYP3A4, which is can be a problematic enzyme. None of our other meds are metabolized by the CYP enzyme, so they're not affected by those kind of drug interactions. Like this is a medication that would be affected by grapefruit juice. It would be made too strong, right? So we have those inhibitors of CYP3A4, and that causes the drug to not be metabolized as quickly. And then you've got inducers, which would cause it to be metabolized more quickly. And 3A4 is probably one of our more problematic enzymes. And so you we haven't really been that concerned with drug interactions. And I talked about drug interactions in the last episode, and that most of the drug interactions that we're going to see is like, you know, if we're lowering sugar, it could do it more. If it's lowering blood pressure, you know, it could lower blood pressure as well. So be careful with other blood pressure medications. It delays gastric emptying. So if you have a medication like oral contraceptives or maybe a long-acting medication that like Adderall XR or something, like those are the main type of drug interactions. But this one is actually has is in the CYP P450 system with 3A4. And so we have to start worrying about all the different medications, and there's like tons of them that can affect 3A4. So that's the famous grapefruit juice one. So don't take grapefruit juice with Foundayo. It's probably going to make you super nauseous because it's going to increase its levels. And there's a lot of other things you need to be worried about. So to me, is it cheaper? Not really. Maybe. I mean, $800 a month, that's cheaper than the 1,600 a month. So it could be cheaper. It kind of depends on what else your other options are. Um, it's it's an oral medication, which is great, but we just happen to have one that came out before this that you get probably more weight loss from, and then we've got the drug interactions. So I'm not real thrilled with this. I don't really hear anyone talking about it. Even the sources of information that I get all this information from, I would have thought they would have had an entire episode, dedicated to, oh, we got a new medication, let's talk about it. No one is excited about this. I feel like it was kind of like a letdown. Like we were excited, like, oh, maybe it's going to be cheaper, and then it really wasn't. And then it's like, oh, and it doesn't really work as well, and it takes forever to titrate it, and it's got these drug interactions that I haven't even heard anyone mention, but like that's a huge issue. Um, just maybe in the future we'll find a place for this medication, but right now, depending on in how insurance pays and the cost, you might find it better than oral Wegovy, but I would say probably not. And of course, it also has the warning of the affecting oral contraceptives, but like I said, I would worry about that with Wegovy as well, even though it's not on there. So that wraps it up today. That is all of the GLP-1 medications that are approved currently in the United States. And next time, I'm going to talk about ones that are going to probably be approved in the near future and kind of some odds and ends. So that's what we'll talk about next time. So I want to thank you so much for joining me today, and I'll see you next time.